Hello my dear curious and studious students of surgery, myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 98. In this lecture we will explore the suprarenal glands or the adrenal glands. This lecture contains the development and anatomy physiology of the suprarenal gland, that is the adrenal gland, Cushing Syndrome, aldosteronism and its treatment, adrenogenital syndrome and its treatment, Addison's disease, adrenal medulla, pheochromocytoma, neuroblastoma and adrenalectomy. All points are explored in this lecture. Start with the development of the adrenal gland. The adrenal gland is composed of a cortex and medulla, each having different embryogenic, histologic and functional characteristics. The adrenal cortex is the mesodermal in origin and arises from the coelomic epithelium between the 4th and 6th week of the fetal life. It gradually differentiates into a thin peripheral neocortex and a thick inner fetal zone. By the 4th month of the embryonic life, the adrenal glands are about 3 to 4 times larger than the kidneys, but they gradually decrease in size thereafter till they assume normal adult size after first year postpartum. During the process of the revolution, the inner fetal zone gradually involutes. The second part is the medulla, is derived from the chromaffin ectodermal cells of the neural crest during the 7th week of the embryonic life. Now, the anatomy. Each adrenal gland lies along the anteromedial border of the superior pole of the kidney. The triangular shaped right adrenal gland lies close to the inferior vena cava and is usually ultimately related with the bare area of the liver anteriorly. There is a pair of the important endocrine glands situated on the posterior abdominal wall over the upper pole of the kidneys behind the peritoneum. There is the two parts of this gland is, one is an outer cortex that is the secretes steroid hormone, and inner medulla secrete the aniline or noradrenaline, that is the catecholamines, made up from the chromaffin cells. Diameter of this gland is 5 by 3 by 1 centimeter and weight is about 5 gram each gland. Arterial supply of this adrenal gland is from the suprarenal artery, middle suprarenal artery and inferior suprarenal artery. Venous drainage: right suprarenal vein drain into IVC and left suprarenal drain into the left renal vein. Students, here is a good picture of the adrenal gland of the left kidney, clear showing. There is a medulla and a cortex, two parts of this adrenal gland. This is the another good pictures showing the anatomy features of the adrenal gland. Now the nerve supply. Suprarenal medulla, myelinated preganglionic sympathetic fibers, chromaffin cells, postganglionic sympathetic neurons. Physiology of this gland. The adrenal cortex in the adult comprises the three distinct zones, that is the peripheral zona glomerulosa and intermediate zona fasciculata and the inner zona reticularis adjacent to the medulla. Each of these zones are characteristics light and electron microscopic features which distinguish one from the others. There are also functional differences, and aldosterone is produced exclusively in the zona glomerulosa, whereas the glucocorticoids or cortisols are produced in the zona fasciculata and androgens are produced in the zona reticularis. Adrenal medulla constitutes 10% of the total gland's weight. Adrenal medullary cells are polypedral in shape and are arranged in cords. The contain catecholamines and the precipitate chromium salts that stain brown with the hematolike xylene and eosin stain. On electron microscopy, the coarse vesicles contains the epinephrine and non-epinephrine can be identified. Adrenal medulla constitutes 10% of the total gland weight. Now the adrenal cortex, the physiology of the mineralocorticoids. The major mineralocorticoids is aldosterone, which is primarily produced by the zona glomerulosa. Major mineralocorticoids in man is aldosterone. Action of the aldosterone is a sodium retention. Clinical states associated with the increase of the aldosterone production, that is on the primary aldosterone and secondary aldosterone. Secondary aldosterone is a cortical glomerulosa cell tumor and second is a hypovolemia. Physiology of the glucocorticoids. Glucocorticoids in a human being is a cortisol and corticosterone. Metabolism of the cortisol is the cortisol exists in 3 stages: free, bound and conjugated. Physiology of the sex hormones. Gonads produce from the testes and estrogen adrenal virilism due to the excess adrenal secretion which produces the clitoral hypertrophy, labial fusion in female children, and increased muscle mass and accelerated growth of the axillary and pubic hairs in the male children. This is the physiology of the sex hormones. Androgens are also influenced by the ACTH secretions, but they cannot exhibit ACTH secretions by feedback mechanism. This is the same picture of the anatomy of the adrenal glands. Now the control of this secretion in adult 10 to 30 milligram per day cortical production. Hypothalamus secrete the CRF and promote the release of the ACTH from anterior pituitary. It stimulates the ACTH stimulation the adrenal cortex and to produce the release cortisol. It increases the blood level of the cortisol and it inhibits the further release of the CRF from the hypothalamus. This is a negative feedback regulatory mechanism of the adrenal gland and its hormones. Now the next point is the Cushing Syndrome. Cushing Syndrome is caused by increased plasma glucocorticoids level due to the enhanced production of the cortisol by the adrenal cortex. May be the result of the adrenal cortical adenoma or carcinoma or due to the increased secretion of the ACTH. Pathology of the Cushing syndrome is the Harvey Cushing in 1932 described this syndrome caused by the adrenal cortical hyperplasia due to the increased production of the ACTH with loss of the normal duration, diurnal variation of the ACTH release, and these may be the failure of the feedback mechanism. Atrophy of the remainder cortex and cortex of the opposite side. Atrophy due to the inhibition of the ACTH secretion by the excess cortisol secretion secreted by autonomous tumor. Now this is the difference between the normal healthy adrenal glands and the Cushing syndrome affected adrenal glands. Healthy looks and the Cushing syndrome looks like the release from the adrenal glands. Too much adrenaline is released from the adrenal glands. This is the typical face in the Cushing syndrome. Clinical features most seen in the third and fourth decade: obesity and bone facies, buffalo lump as we seen in the previous image, typical face, moon face and buffalo hump, excessive accumulation of fat around the head and neck, female oligomenorrhea and amenorrhea, acne, echymosis, increased blood pressure due to the sodium retention and atheroserosis, muscle weakness due to the muscle wasting due to the decreased potassium concentration and osteoporotic bone. Special investigations are Cushing syndrome depends on the demonstration of the hypercorticolism, that is the screening test, determination of the free cortisol in the urine, plasma ACTH measurement, dexamethasone suppression test, 1 milligram of the dexamethasone ingest at midnight at 8 am and the morning plasma sample should be taken. In normal subject level should less than the 5 micromilligram per 100 ml and Cushing syndrome above is the 5 micromilligram per 100 ml. Methapone test, A.C.T.H stimulation test, CT scan, X-ray of the cell, or tertia or angiography of the adrenal gland. Treatment, medical treatment, there is the 3 drugs that is the methapone, aminoglutathione, elliptane, and third is the OPDDD. 3 drugs methapone 2 to 6 gram per day, reducing plasma cortisol level, aminoglutathione, elliptane, anticonvulsant act by blocking steroid synthesis. Side effect is the arsulism and goiter producing. Third is the OPDDD, that is the directly damage the adrenocortical cells and dose is 2 to 5 gram per day. Now the surgical treatment is pituitary irradiation, that is 4000 to 5000 rad, 60 cobalt. Recently 90 yttrium implantation in pituitary fossa. Transsphenoidal hypophasectomy is to be done. Adrenalectomy should be performed. Transabdominal approach by the transabdominal approach. Now the aldosteronism. Aldosteronism means the increase of the aldosterone secretions gives rise to the condition known as the hyperaldosteronism. Primary aldosteronism was first described by the Kohn in 1955. In this condition, there is the excess aldosterone secretion where the ACTH plays a minor but interesting role. Secondary aldosteronism is due to the decreased renal arterial pressure, for which there is excess secretions of renin from the juxtaglomerular cells of the kidney, which acts on the angiotensinogen to convert it into the angiotensin II, which is the chief stimulus of the aldosterone production. Here is a good picture showing the central illustration of the primary aldosteronism. Now the pathology. About 90% of the patients with primary aldosterone have benign solitary adrenocortical adenoma, more common in the left than the right side. Primary aldosterone begins solitary adrenocortical adenoma, bilateral glomerular cell hyperplasia is there. Tumors are discrete and circumscribed. Clinical features of the aldosteronism is the frontal headache, fatigue, nocturia, muscle weakness, polyuria and thirst. Investigation should be done in the aldosteronism is the plasma potassium and sodium level, ECG. The changes are characteristic of hypokalemia, universal normal specific gravity. In hyperaldosteronism, there is excessive loss of the potassium in the urine. And fourth is the urinary specific gravity. Patient with the hyperaldosteronism characteristically produce the large volume of the urine with low specific gravity. Aldosterone excretion in the urine. In normal individuals with salt intake patient usually exceed the less than 10 micromilligram per day, but the primary aldosterone patient exceed the aldosterone between 15 to 50 micromilligram per day. Next is the spironolactone test. 100 gram of the aldactone 4 times a day is given for 3 days. While a patient is on normal sodium intake, the serum potassium level should rise by the minimum of the 1 millicoulomb per liter if there is a hyperaldosteronism. Patient with other causes of hypokalemia will not show any increase. And seventh is the plasma renin level in the primary aldosterone. In present, the volume will be normal or low, whereas the secondary aldosteronism, this level will be high. Now the treatment, first is the medical management, in which the spironolactone is an antagonist of the aldosterone but does not alter the production of the aldosterone by the adrenal. Decreases serum sodium and serum potassium. Dexamethasone 2 mg daily per week. Surgical treatment is the primary aldosteronism, decrease the sodium and increase potassium intake. Affected gland is removed entirely. Adrenocortisol hyperplasia, total or subtotal anerectomy should be performed. Now the next entity of this lecture is the adrenogenital syndrome. This adrenogenital syndrome may appear at 3 different times of life: at birth, in childhood, and in the adult. At birth, congenital adrenogenital syndrome showing the manifestation at birth is by far of the most common variety. Second, in the childhood, in this age group, adrenogenital syndrome is often due to the adenoma or carcinoma of the adrenal cortex. And in the third adult life, the adrenogenital syndrome is usually due to the tumor. It is seen more commonly in the women. Now the estrogen secreting tumors are: in the male, gynecomastia, it develops gynecomastia, premising hair change, atrophy of the testes and penis. And in the female, this adrenogenital syndrome develops in the Cushing syndrome, increase in the urinary estrogen, 17th hydroxycorticosteroid and 17th ketosteroids. Treatment is the surgical excision of the adrenal gland. Next is the adrenocortical insufficiency or addition disease or chronic hypocorticism. Due to this disease is of less importance to the surgeon. This condition is due to the progressive destruction of the 3 zones of the adrenal cortex and medulla with lymphocytes infiltration. Clinical features of this addition disease is weakness, weight loss, and fatigue. Hyperpigmentation is the form of the irregular dusky pigmentation of the skin. Due to the deposits of the melanin are noted in approximately 90% of cases. Now the investigations: high plasma concentration of A.C.T.H is found there. Treatment is hydrocortisol sodium succinate 100 mg IV, and in the chronic stage, cortisone acetate 25 mg IV should be given. This is the typical addition disease, Waterhouse-Friderichsen syndrome. This syndrome with severe systemic bacterial infection, particularly with the meningococci. Clinical features is hyperpaxia, rigor, cyanosis, vomiting, acute corticosteroid deficiency, petechial hemorrhage. Treatment is high dose antibiotics, hydrocortisone sodium succinate IV or IM 100 mg 8 hourly. Now the next is the adrenal medulla. The physiology of this adrenal medulla is the cell of the adrenal medulla secretes a large number of the biogenic amines which are known as catecholamines. Mainly 3 catecholamines are found in the adrenogenially inverted human tissues: dopamine, norepinephrine, and epinephrine. These catecholamines are synthesized in the brain, the nerve endings of the sympathetic neurons, and the chromaffin cells of the adrenal medulla. Dear students, here is a good image showing the adrenal medulla. Cortex and medulla is clearly seen. Now the physiology of the adrenal medulla is: phenylalanine is covered by the tyrosine hydroxylase to L-dihydroxyphenylalanine, that is the DOPA. DOPA is a decarboxylated and to L-dihydroxyphenylethylamine, that is the dopamine, by aromatic L-amino acid decarbonylate. Dopamine is hydroxylated by dopamine, that is the beta hydroxylase, and L-norepinephrine PNMT, phenylethylamine N-methyl transferase, is responsible for the transformation of the L-norepinephrine to L-nepinephrine. PNMT is available exclusively in the adrenal medulla and the organ of the Zuger candle. This human adrenal medulla epinephrine is 80% and non-epinephrine is 20% of total catecholamines constitutes. Now the fate of the catecholamines: the epinephrine and the non-epinephrine is important to uptake and retention into the postganglionic neuron and sympathetic nerve. Inactivation of the circulation amines, that is the epinephrine, the cardiac and vascular muscle cells and collagen and elastin. catecholamines inactivation by the two enzymes, that is the catechol or O-methyl transferase COMT and monoamine oxidase MAO. COMT means the inactivation of the circulatory catecholamines, and MAO, that is the inactivation of the catecholamines in the cytoplasm of the nerve ending and peripheral tissues. Now the next point is the pleochromocytoma. This is the functionally active chromaffin tumors which may be located in the adrenal medulla and other sites of the sympathetic ganglion or chromaffin tissues. The term is derived from the Greek word phaeos, which means dark, or chroma means the dusky, as these tumors stains deep brownish color when exposed to the chromium salts. This tumor is derived from the primitive cells originating in the neural crest, which can differentiate to form the pleochromocytes. This tumor has a tendency to produce the large amount of the catecholamines, primarily norepinephrine. Now the pathology is the pleochromocytomas often involve the right rather than the left adrenal medulla, and in 10% of the cases it may be bilateral. Microscopically, this tumor tends to be circumcised and yellowish brown, but occasionally this may attain a large size, large growth, frequently exhibit the area of the necrosis, hemorrhage or cyst formation. When treated with solution of chrome salts, this tumor turns dark brown to almost black. Tissue are transported by thin walled vessels, the wall of the which are lined by the cells of the tumor. Dear students, here is a good picture showing the pleochromocytoma of the adrenal gland. This is a pleochromocytoma. Now the clinical features are pleochromocytomas may develop at all ages but are usually encountered between the ages of 20 to 50 years. This tumor presents a clinical picture in a bizarre fashion, which is in the adrenal sympathetic syndrome. A sign and symptoms due to the increase of the secretion and of epinephrine and non-epinephrine. Epinephrine secretion symptoms are sweating, tachycardia, hyperglycemia, and norepinephrine secretion symptoms are anterior stimulates, arterial tone, increased vascular resistance and diastolic pressure. Investigations, excretion rates of the urinary epinephrine and norepinephrine, measurements of plasma epinephrine or non-epinephrine, provocative test by IV histamine. Localization of the adrenal tumors are conventional urography. Second is this conventional urography may show the downward replacement of the kidney. It is large adrenal mass. Second is the ultrasonography. This technique is rarely able to identify the adrenal neoplasm smaller than 2 to 3 cm, and computed tomography, that is a CT scan, the greatest advancement of this technique as its ability to detect the lesion less than 2 cm in size. Then the adrenal imaging by using the 131 I-19 iodocholesterol attempts have been made to image the various tumors in the adrenal gland. Third is the arteriography. Although associated with some risk, this technique has been used to localize the pleochromocytomas of the adrenal gland, which is highly vascular. Adrenal venography. This has an advantage of the sampling of the adrenal venous blood for the measurement of the corticosteroids. Now the treatment, medical treatment. The main treatment of the pleochromocytoma is a surgery. The place of the medical treatment is by the oral phentolamine, that is the Regitine 20 mg 3 hours, phenoxybenzamine, dibenzaline, alpha adrenergic receptor blocking agent, beta adrenergic receptor blocking, that is the propranolol 60 mg per day should be given, and the surgical treatment is the transabdominal approach for the adrenalectomy should be performed. Now the neuroblastoma. This tumor is almost confined to children and more than 50% occurs with the first 2 years of life and 80% before the 10 years of life. Now the pathology. This tumor ends to occur more on left side. Microscopically, the tumor is soft and consistency of the many attain a large size. It is a bilateral in a few cases also been seen. Tumor is soft, inconsistency, undifferentiated small round cells, neoblast, fibrin, longitudinal bundles, round holes around the cell masses, appearance of the rosette and pseudo rosettes. Now these neuroblastoma spreads by the two routes, blood spread and the lymphatic spread. Blood spread metastasis is quite common, particularly to the bones, 30%, liver 20%, skull, brain 11% and lungs 9%. Where the lymphatic spreads occurs is usually late. Renal lymph nodes are involved in 25 cases only. Now the clinical features are the weight loss, vomiting and abdominal pain, abdominal mass and swelling is the most common symptoms. Now the investigations is the urinary excretion of the catecholamines and metabolites of the catecholamines should be measured, liver function test, treatment, total excision of the adrenal gland along with the tumor is the treatment of choice. Sometimes the tumor bleeds a lot which becomes hazard for operation. Fresh blood replacement is required for that. Excision should be followed by the post-operatively irradiation. Combined with the chemotherapeutic drugs should be prescribed for metastatic cases. Now the next point is the adrenalectomy. Usually the left side is explored first due to the fact that the left gland is more often affected by the adenomatous or carcinomas. If the tumor is found, adrenectomy is carried out. If the left gland is seen to be atrophic, it is highly probable that there is a tumor of the right side which should be operated on. Approaches for this operation is anterior and posterolateral. When bilateral adrenectomy will be required, the preoperative corticosteroids of cortisone, A.C.T.H, intramuscular 50 mg, 24 and 48 hourly, and intraoperatively IV hydrocortisone succinate 100 mg IM should be given. Picture of the adrenalectomy is clearly seen. Dear students, here I tried to explore all points of the suprarenal glands and the adrenal glands. To know the detail, you must refer a textbook of surgery. Here is the end of our surgery lecture number 98, that is the suprarenal gland or the adrenal gland. Thank you.